Welcome back for week 4. Welcome to the guys online for your first sort of live session, as it were, after the talk earlier this week. All blends into one. And so week 4, if it actually decides to go. So these are learning objectives that you've all seen before. So we finished with the question. Now you want to know how to set a question. We spent a couple of weeks on that because it's so critical. And now we're talking about selecting and justifying a suitable study design for answering the above question that you've already set. So we move on to more actually doing research now, rather than thinking about it, conceptualizing and stuff. But that doesn't take away from how important that bit is. And what you'll see as we move through the study designs is how critical that question is. And the only thing I want to say in preface to the whole thing is, if you get to the stage where you're doing your study design and going, not sure whether this is right or that's right, the problem is usually in the question. So you just go back and start doing the question again. And as Professor G said, most of the time when you're doing grant applications and so on, is spent developing that code question and going back to it over and over and over again until you've done it so many times that you can't be bothered to log onto Teams and update the application. Okay? So week 4, how to do research. So we'll talk a bit about different study designs, and there are squillions of study designs, and my top tip as a kind of keen amateur researcher is the more wordy the study design is described in the method section of the report, the least or the less understanding the researchers had of their study design, and the more they're trying to hide stuff. Okay, so unless who's it? Is it Einstein or something said you've got to be able to explain it simply to understand it? The least, if you have to read a method section 3 or 4 times, it's a bollocks paper. Just put it down, frankly. Okay, because you should be able to explain this very simply. We'll talk a bit about the advantages and disadvantages of each, and those are great big long lists, and people literally make careers out of doing. That's what methodologists do. Okay, so I can't cover it all, and I don't pretend to be able to cover it all, but I'm sure between all of us we can get most of them. We'll talk a bit about choosing an appropriate study design for a question. That's quite hard because of the way that the weeks have worked out, but hopefully you'll be able to start thinking some ideas. If I want to ask a question like that, maybe this study design, the reality is most of it's determined by money. Okay, so why is trial design so important? Well, it's really how you do your project, right? It's that experiment. When we talked about you've got to set a question you can answer with an experiment, it's like, how do I do that experiment? Essentially, that's it. And it completely relies on the question, like I said. And I'll keep coming back to it because it's the biggest lesson I learned doing research is invest time in designing your question and understanding it and really knowing it inside and out. So it totally relies on the question you want to ask. Okay, if you want to ask about coal miners from the 70s, you need something with a retrospective thing. If you want to test a new treatment, you need something that allows you to do stuff prospectively. If you want to look at how many people have COVID today and why, you need a third kind. So it really depends on your question and so on. And then probably the next biggest thing is your resources. And they can always get more resources, right? If you beg long enough and hard enough, someone will give you something to make these things happen. If you're trying to do a massive trial in a dinky, what's that thing in King Edward, that emergency walk-in centre thing, and you want to do something massive about surgical intervention for femoral fractures, for example, there's no resource there to do that. And of course, there's ethics. And I read this and was like, I'm very pro to skipping over the ethics and like not thinking too much about it. Then I thought, what about that cancer study they did in the 50s with doctors in lung cancer? That's an observational trial because they couldn't say, you smoke and you don't, and let's just see who gets cancer and dies in 25 years, right? So ethics plays a role, and that's why certainly in the trial, the few large-scale trial designs I've been involved in, ethicists are pretty early on involved because if they say no, that's game over. You'll go back to the start and maybe even redesign your question. So considering ethics early on is really important. And then there's the practicalities of delivery. Proper big prospective interventional trials where you're dividing people into groups of treatments and stuff take a lot of people and they take a lot of money, and people aren't all the same. Some people work hard for their money, some people don't work hard for their money, some people get it, a lot of people don't, and so on. The practicalities of doing it are really important, even down to Laura needing a new monitor to do our trials here. That sort of basic level of practicality is really important. You guys know that better than I do. Sit squashed in a tiny little office, 8 of you, like coal miner's cottage, right? That's no good, is it? You can't do quality work and focus and so on. So the practicalities are really important. And I caught the tail end of the professor's discussion with you the week before last about trying to provide that infrastructure. It is really important to do that. You need the infrastructure to do it. So what about types of trial design? Well, I guess you probably already have an idea about this, but if you had to divide it into the two biggest kind of groups of trial designs, then you've got experimental, where you're doing something and changing something and seeing what happens as a result, or you're just looking at what happened or what is happening and just recording it and analyzing it. That's it. So you either stick your oar in or you don't. You either change what is going into somebody or you don't. I'll just see if that's someone not hearing us. Hello? Oh, my water meter guy has arrived, but I'm here instead. Okay, so you're either changing something, okay, and seeing what happens, or you're just looking at what's going on. All right, it's going to ring again. I'm going to ignore it. It didn't sound very interesting. Okay, so there's a few points to raise before we go into the different trial types. Okay, so the first is the unit of observation. All right, now these are things that as I was reading for this and thinking about it, I thought, well, it's kind of obvious. Actually, maybe it's not, and you need to predefine that to decide what you're going to do. Now in a spine, our unit of observation is the vertebra, or maybe if we're lucky, 2 vertebrae. Okay, it's very seldom much more than that. In orthopedic surgery, it might be an ankle, left or right, or something like that. In medicine, it might be a heart or something, or it might be a whole individual. In something more sociological in your research, that person and their kind of environs and interactions and so on. If it's a dentist, it might be individual teeth, or the whole bottom jaw, or the whole mouth, or a whole group of kids in a certain area that have tooth decay and so on. So the thing there is, what's the smallest quanta of observation? Are you counting individual people, individual cases, individual bones, individual teeth, individual hearts, individual aorta, individual, I don't know, systolic blood pressure measurements? I don't know. But again, I never thought about it. I just thought, oh, it's a person, isn't it? One case is one person, but one case is not the same as cases. And ankle fracture is a great example. What do you do if someone breaks their left ankle, goes in a trial, completes, breaks their right ankle, goes in a trial, completes? Is that the same case? Is that 2 cases? Hopefully it's 2, because you can double your recruitment. Brilliant. But is there something fundamentally different about left and right ankles? Maybe most people are right-footed. Does that mean their left breaks more often? Don't know. But thinking about the unit of observation is really important. The most common is, of course, individual people. So most of the research stuff you guys work on, I'm sure, is individual people, especially because you all seem to be focused on physiotherapy research, right? And no one moves in isolation. So the most common is an individual person. But you can kind of group those people together. And this is where these terms cluster randomization and ecological studies come in. Because you go, well, an individual person doesn't really mean very much, but perhaps all the people in that group in Whitechapel, we can put those together and compare that whole bunch, averaged out or somehow manipulated so all their data gives us one value, and compare it with those, in Newham, and then those in some of the other London boroughs, the names of which I don't know. Okay, and you start pooling them and comparing them around, and suddenly your trial, you can see already, starts to geographically get bigger, or perhaps chronologically get bigger. And the bigger it is, and the more diverse you remember, the more powerful it is potentially. As ecological studies, things like rates of miscarriage in the Amazon rainforest versus rates of miscarriage in in China versus those in Antarctica or something. I don't imagine there's very many down there, but you never know. Okay, so the geographic separation, the influence of geography and so on, lets you pool cases from an individual area rather than by patient characteristics, but by kind of where they are or perhaps what they do for a living. And that's grouping them ecologically. You pull those results, you get one number. This is the rate in northern Russia of miscarriage. Let's compare that with London. And perhaps that's a useful thing. Less useful when it comes to the sorts of work that we do on a day-to-day clinical level. But in the population health level, like COVID again, we keep coming back to, can be really handy, right? It's certainly how things like the travel bans and stuff are calculated, isn't it? We have this rate, France has that rate. Are those two so different that we're going to, harm people or not? All right. Moving on. So I really like numbers and data. There's something very pleasing about the fact that numbers can't lie, they can't hide, they can't be anything that it doesn't say they are on the paper. And I really like that. I think that's why I like working in an office on my own. I have very few friends and stuff. But you have to think about variation in the data starting off. So it's no good spending millions of pounds and thousands of man hours, or person hours rather, collecting data and reams and rafts, and we've all seen those gigantic spreadsheets, and people are terribly impressed, aren't they, when they have a spreadsheet that's got 1,000 columns and 24,000 rows and stuff. And you're like, well, you just didn't collect the right stuff, did you, for your question? Okay, and that data is going to be all over the place and skewed data. Okay, so you need to think, well, how is my research methodology going to collect that data, and what's that data going to look like? And so on. If you're getting spots on your scatter graph all over the place, then marshalling that into some sort of pattern, we can only analyze patterns, it's going to be next to impossible, or it's going to be so vague you can't draw a conclusion for it. If you collect miscarriage data on the entirety of Russia north of the equator and compare it with the entire world south of the equator, the data can be so broad and so all over the place, the chance of you finding a difference is probably quite low. Everything will regress to the mean. The data will be so variable that your computer program will just go, it doesn't make sense, and your p-value will be massive because it will just be completely random. Okay, so you need to think with the variation in data. Is there a systemic variation because of how you've built the trial? Have you built it or conceived it in such a way that you've restricted access to data from some section of your sample or your cohort? And so you're systemically ruling out some data that can lead you to a good conclusion or not. For example, a good one, for example, is like publishing the trial material only in English. So only people that are kind of good enough to really understand it get recruited. And that's a really barn door example, isn't it? Because, you know, everybody speaks English, right? Well, not always. And if you exclude them, maybe there's something very systematically different about them. That's a good example. Sometimes you can just get random scattering of data, or never forget that patients lie. They didn't make stuff up. Yeah, I never smoked. No, I don't smoke. I gave up yesterday. That's the one we see a lot in orthopedic surgery. No, I don't smoke. When did you give up? This morning. You know, those things, you know, maybe that's random, maybe it's not. Don't I suspect it's probably not. You know, there's random variation in data that can really upset your results. So you need to build your trial in a way that allows for that if you think that's going to be the case. So you address your systemic variation, and then you go, well, what if just by random chance, there's a lot of, my data is so spread I can't compare it. Can I somehow construct my study to allow for that? For example, maybe we group people together as Royal London patients, you know, Mile End patients and Newham patients, and treat those as the individuals. There might be variation within that unit, but overall there probably isn't too much between those groups. You see what I mean? By bunching people together and chucking them all in the same pot, you start to come up with ways of reducing that randomization. There's replication. Maybe you just keep taking data over and over and over and over again from the same person. So you might check their blood pressure every week for a month and average it out and say, well, that's probably an accurate reflection, rather than they ran to the practice on a Monday and they walked on the following Monday and so on. Your sample size, we talked a bit about. Generally, a bigger sample size is better, but it can get out of hand and it becomes impractical and so on. Maximizing the response rates is a good tactic. So the more, you know, if you just recruit 100 people, but by the end of your trial you've only got 20, you've lost 80 people. Your variation in data is much more pronounced because you've only got a fifth of your patients left. So working hard to keep them in the trial to the end, or in your study to the end, is important. Making sure they actually do reply to things. So in spines, we do a lot of scores. And my colleagues, bless them, are stuck in the 1800s with still pen and paper and crappy old photocopies and stuff to do it. All right. And so people just go, nah, I'm not filling that in. I do. I'm not done it. I'm not bothering with that. Okay. So trying to come up with ways of maximizing your response rate can reduce this variation, because you're getting the same person all the way through the trial reporting data. Stratifying them, we've talked about. So blocking them together, either by characteristic, for example, age, you know, we've seen those, right? Age 60 to 70, 70 to 80, 80 to 90, or 100 plus, or something like that, or by location and so on. You can have parallel or crossover designs as a way of doing it. So parallel is you have treatment A, you have treatment B, and then they run in parallel to each other. So what's the result of treatment A versus the result of treatment B? Or you can do a crossover design. So, right, you start with treatment A, you start with treatment B. In 6 months, we're going to swap you over and see which of those treatments controls your situation better. Blood pressure tablets are a good example. You can't cure hypertension, right? Unless you have a heart transplant or something. That probably screws up so many other things. It's heavily confounded. Okay, but you know, you take your tablet for 6 months for your hypertension. You stop. You wait a month for it all to wash out and your blood pressure to go back up. You try treatment B. See which one works best for you. So you're your own control. Maybe that reduces variation and so on. And factorial designs are about controlling different factors and allowing for those in your study design. So you can actually design trials that you can assess the impact of several factors on a patient at once. You need to know that ahead of time. You can't go back and do that, because then what you're doing is just going, oh, I found a confounder. Okay, let's bury that in the method section so that no one's going to read. Okay, except Professor G, he can't slide anything by him. So what about causality? All right, so what about causality? Can observational studies, where we haven't done something to someone, we're just looking, prove causality? I keep looking at you. I don't know why today you're my figure of fun. Can you, through observation only, so just looking at groups of people, prove causality? Yeah, okay, total guess. But yeah, you can. Okay, but can you really? Well, no, not really. You can show that it's mostly, you can minimize the doubt that it causes causality. You can't say for sure. And that's one of the age-old things of science, isn't it? Just because the sun came up this morning doesn't mean it's going to come up tomorrow. It's London, it never comes up here. All right? But just because it come up this morning doesn't mean it won't, or doesn't mean it'll come up today. It's just very likely. Okay, actually it will happen because momentum, orbits, all that sort of stuff. Okay, but that's the point. And so what do we do to prove causality? Well, actually think about it. We know that antibiotics treats pneumonia, right? We know that because if you have two patients with pneumonia, you give one antibiotics, you don't give one antibiotics, they die. 99.99999 irrefutable. Same with the smoking and the lung cancer. Same with physiotherapy and ACL reconstruction. It just kind of works, right? Never have surgery for ACL, it's horrible. Okay? But in observational studies, we can't do that. We can't eliminate all the potential factors that cause something. Okay? And then say, definitely, as best as science can prove, that's the cause or not. Cause of recovery, cause of death, cause of disease, whatever. So we have these criteria, the Bradford Hill criteria. Some of you heard of these? Yeah, so everybody always nods when you say this. Yeah, I've heard of the Bradford Hill criteria. And then when you say, well, what are they? People go, I'm not sure. So this is a list of criteria that we use in observational research, where we're just looking at stuff, we're not changing anything, to say, well, look, on the balance of probability, it's likely this is a cause that we've identified here. And this is them. So it's no good doing an observational study and saying, well, everybody had cancer and then they started smoking, so smoking causes cancer. Doesn't make sense. Okay, so the cause, your anticipated cause, must be before the disease. Number one, obvious, right? You know, I was hit by a car, then I crossed the road. Well, no, you might have been thrown across the road, but you didn't cross the road. See what I mean? It's obvious, isn't it? The association should be plausible. Well, I got cancer, then I started smoking. Doesn't really make sense, does it? Because you're seeing doctors and they're telling you not to smoke and do all this stuff, okay? It's got to be consistent across multiple studies. So if yours is the only study that says lung cancer causes smoking and everybody else says the other way around, one of you's wrong. And if everybody else is saying the other way around, probably it's you that's wrong. So it's got to be consistent. Everybody got to be saying the same sort of thing. The association should be strong. Okay, so going, you know, area under the curve is exactly 0.5, which means there's not really any correlation, or 0.51 is only just a correlation. That can be down to chance, right? You need a strong correlation between your hypothesized cause and your hypothesized kind of effect, if you like. There should be a dose-response relationship. So the stronger the exposure, the more you smoke, the stronger your response, the more you have cancer, or the more cancer you have, or whatever, okay? And removing the cause should lower the risk. You smoke, you think you're going to get, you know, the chances are you get lung cancer, you stop smoking, that risk goes down. So these are the Bradford Hill criteria that we use in research. Now, there are other criteria that are similar that are used in clinical medicine, things like proving a pathogen causes a disease and stuff, and they look pretty similar, but they're different. Just saying it in case you were getting muddled up, all right? So the Bradford Hill criteria are what we use to show causality in observational studies. So you can do it. So don't let anyone say you can't, but it's not like the biggest stick in the house, because interventional trials are, okay? So clinical trials. My blue writing, come on, I spend ages thinking of little fun comments. What we really, really want, okay, is a clinical trial. Because it's the best, isn't it? Why is it the best? You again. What's your name, sorry?
Mashuka.
Mashuka. Hello, Mashuka. I'm Brett. I don't know what I'm doing either. Don't worry, carry on. Why are clinical trials the best? Why does everyone go, wow, clinical trials, yay? Why don't we just sit and look through the hospital records and say, Broken femur means you limp and stuff like that.
More detailed?
More detailed. Swing in the dark. I like it. That's good. I mean, you can, because it's mean to pick on people nowadays, isn't it? You, my friend, why are clinical trials the best? She's picked on you because you're eating.
Because you're changing a specific factor.
Right.
Like keeping everything the same.
Yeah.
Changing.
Keeping everything the same and changing one thing. Okay. Anything else?
It's proof.
Dan, limb reconstruction physio.
I am.
That makes a lot of sense after the Pico questions last week, doesn't it? Okay, why clinical trials? Why did Bart's charity give us £3 million for an orthopedic department to do clinical trials? Why are they the best?
Some proof.
Yeah, so they have a higher ability to prove that causality, don't they? Yeah, anything else? You look really excited to be here. I'm loving it. Carry on.
It's stronger evidence.
Stronger evidence.
Yeah, that's the first.
So it's a higher quality of evidence, isn't it?
Well, the reason, yeah, so I agree, it's because you can control some variables, and then that means that you're more certain that whatever you change.
Okay, so you guys are pro research. They're all pro researchers here, guys, online, and I know you guys are juniors. So sorry.
We're in the wrong careers otherwise.
Yeah. So you said you can control the. What do you say?
Control some variables.
So can we control them? Actually control
within within a reasonable grid area. Yeah.
Okay, so how many variables realistically do you think you can control in a cohort of, say, 200 people? Control. Bear in mind, that means you are. They have to do exactly what you say. Bugger all. Okay, bugger all. I know it's bad for me to eat McDonald's, yet since I found that one on Commercial Road, they know my name. Okay, and so controlling even my diet is bad. So what you can do is a trial lets you allow for them. I would say more than control. You can control one, maybe two. Do you get surgery or not? Do you get Dan's rehab or not? Do you get a cast or a boot? Stuff like that. You can control small things, but you can kind of allow for the others. Okay, and that's why it's so powerful, isn't it? We all want to say the C word now, don't we? I love the C word. It tells us everything. We can allow for the confounders. All right. You didn't really think I was going to say something else, did you? Surely you saw that coming, Kat. Okay. So clinical trials, you have to be comparative, right? We know that already. You have to compare one to another. You can't just have like one arm and say, ta-da, their blood pressure went down a certain amount. That's a drug-funded trial by the drug company. It says, look how great it is. And they compare it. They cheat because they compare it with a placebo. Or they take their insulin or their diabetes drug and they compare it to someone who lives on donuts and say, look, blood sugar comes down. Okay, so that's that. Okay, there has to be an end point to your trial. Okay, and the end point, we talked a bit about this last time. So you can see some people online. I'm aware I'm neglecting them. So I'm trying to think of a question for you guys in a sec to ask. So what, let's have a look. Lucy Maria Lind Thomas. That's what it says on my screen here. What's important about a primary endpoint in a clinical trial?
So a primary endpoint is something that the study is powered to look at, and that's like the ultimate thing you want to prove. And then a secondary endpoint is something that the study might not be powered to look at, but it's like additional findings, I think.
Yeah, so that's not far off, is it? So it comes back to your question again. You're trying to find out the answer to a specific question, and the primary endpoint is the answer to that question. So usually in the case of a drug trial, for example, on the medical side, it might be the influence of that medication on a disease state. For example, I mentioned diabetes, the control of the BM, or the incidence of myocardial infarction, the cardiac thing. The secondary outcomes are kind of what you said, really. What else can the data show us? But it wasn't like the focus. It's not the answer to our question. It's just interesting sidelines. And quite often in drug trials, it'll be things like toxicity, or it might be things like the scale of the dose response curve or something like that. But you're quite right. The headline and the clinical bottom line will be your primary endpoint. So a clinical trial has to have a primary endpoint rather than, say, an observational one where you go, well, actually, kind of there isn't an endpoint. It's just we decided to make the observation at this time when we got bored of looking at the data. As a clinical trial, it starts on this date, and by this date, ideally, you have your primary endpoint reached, whatever that might be. And subgroup analyses are, can be some of these secondary endpoints. So you might look at your massive cohort that you've treated with hypertension, and you might say, well, what we're going to do is take that cohort of 1,000 people and chop it up in different ways by age or gender or geography and things like that. And we're going to compare the effect of that intervention between those two small bits of group. Now, the problem with that is, again, this is another top tip. When you read a paper and the primary endpoint is like half a line and the subgroup analysis is 3 paragraphs, they're lying to you and you should throw it in the bin. Because no trial, by definition, is really powered for subgroup analysis. Otherwise, that's the main trial, in my mind. There's, we're covering this in an hour. There are ways to do that and allow for that. You might say, well, the whole trial is 1 million people, and within that, there's enough power to look at, say, males aged over 50 or any other subgroup. Okay, but you need to set that out in advance. Otherwise, you've got to question that conclusion. So if in your study report that you read in the Lancet or whatever for the big, I'm talking the big kind of proper trials, that we've all heard of, that's not mentioned a priori, i.e. before this experiment started, then it's bollocks. And you shouldn't really pay too much attention to it. Okay? Oop, I clicked on something else here, so that's just a bit upset with me. Sorry guys, we've got the slides on a projector in here, and it's bamboozling my tiny mind. I don't know what's going on. Hold on a sec. You should, and then there we go. Okay, so who knows what this is? Dr. Etienne Chu. Your time to shine. It feels a bit like Blankety Blank, which my 9-year-old son loves. What's the consort all about? Etienne Chu is not there. Okay, Yassine, you're a bright guy. Tell us about consort. Have you heard of that?
I'd love to tell you I haven't, unfortunately.
All right. So this is the cheat sheet for clinical trials, right? It tells you exactly what to write in your report, and to my mind, tells you exactly what you need to think about when you're doing it. So the consort was a consensus statement written by a load of bright guys who I'm sure Professor G knows personally and has drinks with. And it tells us the things that we have to mention when we're describing the methodology and to an extent the results of a clinical trial. And what that means is when you're designing it, these are all the things you have to think about. You have to be able to say something about each of these that's defensible. So title and abstract goes without saying, fine, that's really a cataloging thing. Background and objective, you have to explain why you're doing it. You have to have specific objectives and hypotheses. You have to ask the question that has an answer. Okay, you have to describe your participants, describe your interventions, describe your outcomes, describe your sample size. And look, how was it determined? Well, that alone is a massive question. How did you decide how many patients you needed to test your antihypertensive? Again, the drug trial funded papers will sometimes skip that sort of thing. How did you randomize? This isn't the whole list. How did you randomize? How did you allocate? How did you hide it? And so on. Okay, so these are all important things that you need to think about when you're designing your clinical trial. And there are lists for all different trials as well, of course, that we all know about and are familiar with, so we won't go into today. So what's the big strength? Is the randomization, isn't it? Oh, why, Becca, you were late. Becca, you were late. So you're our figure of fun number 2. Okay, why is randomization so good and why do we care so much? Because frankly, it's a pain. But we all know to say randomized controlled trial, right? We all know that's good. That's good. I did a randomized controlled trial. Yay. Why?
Eliminate bias. So
Eliminate. What is bias?
so you don't have all of one certain group in one intervention group.
That is an example of one type of bias. So what is bias? Let's see. Etienne, are you back from whatever you're doing? No, he's not back. Okay, let's go down. Catherine Borra, it says here. What's bias? You have to excuse me if you're somebody extremely high up in the university just watching out of interest, and I'm sorry.
I'm really not.
Okay, in that case, tell us what bias is, please.
I guess it's a kind of prejudice that comes out from your results towards a particular group. within your study?
Yeah. Anybody, any advances on that? He's frowning. Maybe he's thinking. Maybe he's got the answer.
Well, it's a very general thing that it's
Yeah,
when
it
you-
is.
It's kind of like irrational elements entering your decision-making process, which is really general. But
Yeah, sort of. So that's what we think of data as bias. Bias in a sciencey kind of testing is a systemic error in your trial design, isn't it? You've built your design so only those people with a reading age of above 15 in the English language can participate. So you're only ever going to have results applicable to that group. Or, you know, people, you ask them about their childhood exposure to asbestos. You know, you're asking people in their 60s with mesothelioma. They can't remember, so there's recall bias. You ask only white 6'8" spine surgeons to recruit patients, so I'll only put certain patients in your study. So selection bias and so on. Okay, so all those things can introduce a bias to your study. It's a systemic thing you've designed into your study to give you a crap study. That's why we try and have lots of people in the team to try and remove that, because we all see things from different perspectives, right? So what does randomization do? This is slightly off topic with the bias. Randomization seeks to control those confounders. Okay, it's all about the C word, control those other factors. If you have 1,000 people, you're going to get fat, thin, young, old, you know, with every comorbidity under the sun, with every income under the sun, with every level of education. And overall, if you averaged each of those things, they should just kind of be in the mean, shouldn't they? Do you see what I mean? You'll have an average age, an average, which is kind of representative of the whole population. Actually, that's probably not true, because if you do loads of means, then you end up with this weird thing where you've repeated a test over and over again, and so on. And then you get false positives, which is why all these papers that say, oh, we did a t-test that compared all these characteristics of our two populations that were the same, that's bollocks as well. And it's a useful one, though, because you can get away with it because no one really knows that that's rubbish. And you know, we have that p-value less than 0.05. That means every one in every 20 tests you do is a false positive. If you do 20 t-tests, then one of them is wrong by just random chance. Exciting that we'll cover in the numbers, okay? But randomization seeks to even all that out, give you a level playing field. Think about a football pitch, right? Is how I think of it. No two blades of grass are exactly the same, but overall, Man U's football pitch is pretty flat, right? Okay, every blade of grass is slightly different, but it's flat across the board. That's what randomization does. Whereas if you took just kind of all the short bits on one side, all the long bits of grass on the other side, it would look weird. You'd have a kind of a step pathway. That's how I think of it. Really basic, because I'm a bit dumb. Okay, so that's the real strength of a randomized controlled trial, is the randomization. And that is why so much effort is invested in it. And it can be really difficult to do, actually, can't it? Because not least of all, some surgeons really believe one way or the other. They really believe that actually if you are, you know, a 39-year-old white male, you really benefit from fusion from your back pain. I've seen it. My experience is I've seen it. But if you're a pregnant mother with twins, actually it's better to have Dan's physiotherapy. I just believe it, and so on, for example. Or you might say, we have the facilities for this treatment here and I can do that more quickly, and so on. And all those sorts of things can really challenge your ability to randomize people. It is really hard. I sit there and I think, you just roll the dice, or you get the number off the computer, or you phone the randomization line. I remember doing it for the Wolf study, you know, doing the randomization in theatre. And I remember people saying, they'll just do better with VAC. Let's just do a VAC and just not put their name in it. Okay, it happens for real. So you need to try and identify those barriers to randomization ahead of time and deal with them, however that might be. And good trials go all out to do it. They'll say they are randomized by someone in a different department who's never met them, has nothing to do with them whatsoever, or the phone line or whatever, and they will do the randomization. Okay, and the idea is it removes the influence of allocation bias, this idea that, well, I just believe Dan's going to do better with his ACL injury following physiotherapy. Don't know why, just because. Okay, and you're going to do better with surgery because, you know, I don't know, you're under the care of someone who I think is really good at it. You remove that allocation bias so you control those confounding factors. And even better, if you randomize, you control the factors you can think about and identify and those you can't, if you randomize properly. I don't know what influences ACL outcomes. I don't actually care what influences ACL outcomes, but it may be there's something in our genes or something about our day-to-day activity that influences it that no one's thought about. Whether you get the underground to work or not, whether you have stairs at your local station. And by randomizing, you level all that playing field out. So the only thing is that factor that you mentioned earlier that you can control. That's ideally, on average, the only difference between the two groups. And that is the strength of clinical trials. Okay, the rest of this now is just nice, pretty information to fill the rest of the hour. Okay. So you can randomize people using different techniques. You can do it one-to-one, can't you? Every case comes through, they get randomized kind of left or right, one treatment arm or the other. You can do that on a case-by-case basis, but you can imagine that's tricky. So let's say you're doing a trial about physiotherapy and knee injury. How many knee injuries do you think an average physio department sees in a week? Probably like 200, more maybe. Randomizing every single one is difficult. So you might say, okay, we know that the treatment between the Royal London and Mile End is the same. The knee rehab is the same. So what we'll do is we'll randomize Royal London to Dan's treatment plan and Mile End to Cat's treatment plan, and then we'll compare those groups. So within one treatment arm or within one kind of pocket, they're not randomized, but the centers are randomized and so on. So that's this block randomization. Okay, you're randomizing by blocks. And if you can do that like all around London, you might say, well, we'll have Royal London, Barts, and Whips Cross doing Dan's and a load of other hospitals. Again, I don't really know where they are or anything. Okay, doing Cats. You can stratify them. So you could say, well, what we need is we need roughly the same number of people aged 50 to 60 in each arm to allow us to be fair and so on, because we can't realistically randomize as many people as there are blades of grass on a football pitch, right? We're only going to randomize 200 people, but it's no good if by chance one arm is all kids aged under 18 who play football and Sasson have hurt their knees, and the other side, Cat side, is all 90-year-olds who slipped down a step and hurt their knees. So you can stratify it by controlling it for things like age or BMI or profession or something like that. And the reality is that's what a lot of trials will do, okay, to try and give a bit of direction to the randomization, but not so much it doesn't control for the factors that you mentioned. What's your name? Sorry, I keep pointing at you.
Leo.
Leo. Not so many that Leo's going to be upset with us, okay? And clustering's the same sort of idea. We won't go into that. Okay, so can't remember why I put this picture in. I think I typed in randomization. This is it. Don't know what came up. Just I'm fascinated by the picture that come up when you type weird stuff in. What there is there's notes under the slides, but I can't work out how to show the PowerPoint so I can see the notes and you can only see the slides. So I've written what it is underneath, but I can't find it. Okay, so protocol. So a few of my sort of study group are on the call. I think maybe only Yassine today. And they will know that after thinking about the question, the protocol is the most important thing. The protocol is your recipe book for your trial. This is where all the effort should go in, all of it, and then 1% should be in actually doing the trial, because then you're just following the recipe. I will collect, 100 people. I will randomize like this. I will stratify like that. Dan's treatment is exactly this every time. Cat's treatment is exactly this every time. The people analyzing it are this or that, okay? So it describes all aspects, every aspect of the design and all the steps that you're going to take to effectively reach that primary endpoint. And in fact, this is so important that nowadays, if you want to publish in it anything like a decent journal, you have to publish this first, or at least register it in the Register of Trials. And if it's not, you just won't get published. You've wasted your time. Okay, you need to very clearly set out your inclusion and exclusion criteria. We've spent a bit of time talking about this with the questions. You need to talk about how you're going to collect the data. Who's going to sit at the computer and measure the x-rays or measure the range of movement or the instability in the anterior drawings? How are they going to do it exactly? How are they going to do it to make sure they're doing it the same? How is it going to be analyzed? What tests are you going to do to show similarity between your two groups? And then measure the difference between the two groups and the strength of that association. What about your trial size? What's your power calculation? So we're not going to talk about power calculations because either I'm stupid or the statistician I know makes it sound complicated, okay? But trial size and power calculation, you need enough people to show the difference you anticipate. It needs to be detailed in your protocol. And then there's this idea of intention to treat versus per protocol. You know what that is? Any idea?
Do the right thing versus randomization?
Okay, no. Jess, so what do you think intention to treat is? So Professor G loves all this stuff. I can hear him from here. laughing and going,
Is it to do with what treatment you wanted that patient to have? So say you randomised them to Dan or CAT
Yeah.
treatment, then that person comes into the trial if they're randomised to get Dan's treatment, but they actually end up getting CAT's treatment, then you analyse it differently?
yeah, exactly right. So in a nutshell, intention to treat means you analyse the outcome of that patient or that unit of observation by what they were allocated in the randomisation. So if I damage my ACL, the roll of the dice, and I'm allocated to Dan's treatment, I'm always, whatever happens to me, I'm always going to be analysed as though I was treated by Dan and his protocol. Full stop. Okay. Now the problem is, I might turn up to Dan on day one and go, well, I'm not being treated by him. Guy's a chimp. Okay. And I might hear Kat next door and go, she sounds much better. Go next door and do all the treatment that Kat gives me and have my outcome. Now, if we're doing it an intention to treat, I'm still one of Dan's patients, and you have to measure my outcome as though I'm one of his gang. Okay. If you do per protocol, then what you're starting to do is say, well, in an ideal world, Brett would have followed this, but he didn't. He did something off protocol. He changed his mind that wasn't allowed for in the protocol. So there's different ways of dealing with that. You can either then say, well, actually he did basically none of Dan's treatment, all of Kat's treatment, we'll put him in Kat's group. Or you can say, well, he was a naughty boy. If he swapped over, maybe he did other stuff. Maybe he went and had private treatment as well. Maybe he, I don't know, went and had stem cell injections in Dubai or something really wild. So we're just going to get rid of him from the trial completely and just say he didn't follow anything. He violated the inclusion criteria and so on. And so per protocol is essentially not intention to treat. It's a big subject. That's what I take away from it, really. And some trials will kind of do both. We'll say, by intention to treat, this is the report. We notice that, for example, we're working on a grant application where I expect people to change up to 50% of patients to swap over from one treatment arm to another, which is huge, but it's just the way it is in spine trials. So we're going to try and find a way to kind of report on both so that no one can pick holes in it. Okay, so that's intention to treat versus per protocol. And that's another line you've got to find in these reports. If you go back to consort, there is a mark, kind of a point to say what you did that and how you did it. So what about cohort studies? So that's the interventional ones, right? The clinical trials, the good ones, the money. And he said the money shot, that's not what I meant. Okay. You can do cohort studies, basically where you're looking at a group of people, all right, and you're seeing what happens to them over time. So you can do those prospectively in the main. So we try and do that. We try and say, well, let's look at everybody with, ACLs, follow them over time. Well, actually, you had Kat's thing, you had Dan's, you had someone else, and try and build a correlation without us changing anything, just seeing what happened to them as a result of their injury or whatever in the past. And it follows them forward with time. So you might say, right, what we're going to do at the Royal London is sit in A&E and we're going to get 100 people who present with ACL injury. We're going to follow those people over time. We're going to record what happens to them treatment-wise. We're going to record their outcome at the end, and we'll try and correlate those together. But we are not taking responsibility for allocating them to a treatment or for directing that treatment at all. All right? Now, most papers are retrospective cohort studies in that they look at a whole bunch of people in the past, say, oh, well, everybody died of MI. Let's go even further back and see how many smoked or had diabetes or something. Okay, and they do that thing of this is a retrospective analysis of a prospectively collected database. Yeah, bollocks again, but it's an easy publish. Okay, the cohort should all be from the same population. So it's no good getting one from the Royal London, one from Uxbridge, one from Amersham, one from Brighton, and so on. You really need them from the same population, because what you can't do here is control for those confounders at all. You just have to kind of measure the difference if you can. But you can imagine someone from East London is basically their life is incredibly different from someone in Bristol or someone in the Welsh countryside and so on. So from the same population is good, right, Bex? Yeah, sure. All right. It helps to identify risk factors for disease. So you might get your 100 ACLs and you might, well, actually, 90 of them played football on this football surface on a Saturday afternoon. And you can start picking out risk factors for disease and so on. And the output is it calculates relative risk. So you have your little grid there, your 2x2 table. You have your cases and your controls being those people who don't have disease, which you might get from a general database, or you might say, well, actually, you know, there were 100 people played football on that pitch that day, and 6 of them got ACLs, and whatever, 94 didn't, and so on. And you can start working out the relative risk of injuring your ACL playing on that surface versus not playing on that surface. That makes sense. So your output is a relative risk. Okay, we'll talk about relative risk and odds and stuff in the coming weeks, but relative risk is a good kind of solid output from a paper like this. Okay, so you look at a group of people and you look at their risks and you try and correlate the two. So what about advantages versus disadvantages? Well, on a plus side, you can look at the chronology, you can see what happens over time. You can look at a wide range of outcomes, wide range of diseases. You can calculate the incidence of disease and the risk of disease, and you can look at detailed exposure info, really only limited by how asked you can be to talk to them and hunt through their records. And it has reduced recall and selection bias, because you're getting people at the time of injury, and you might interview them then and there and say, well, what did you do? What were you doing when you had your injury? What are your lifestyle risk factors, and so on. All right, they're not having to recall, it's then and there. On the downside, if you're doing it prospectively, it can be expensive. You might sit in that emergency department of the Royal London for 3 years waiting for 100 ACLs, or you might get them all in one night. Kind of thing. You know, you don't know, and then you have to follow them until they reach the endpoint that you stipulate. And some of them might never reach it. Downs players might take 10 years to get back to playing football. Cats might take 6 months, but you don't know the outcome until they reach that point. If it's a rare disease, for example, you're sat down there waiting for retroperitoneal mesothelioma. Don't even know if that's a thing. Sounds rare. Okay, you need a massive sample, so you might be waiting forever. Okay, for those things, it's easy to lose people to follow up because it's typically less intensive compared to a trial. People change when they get a disease. So the minute I have my first heart attack, okay, I will stop going to McDonald's down on the commercial road. So my behavior will start changing, which then influences the outcomes. Because then someone says, do you eat fast food? I say, well, no, dirty. So if someone says to me today, do you eat it? I go, yes, love it. Okay, so people's behavior changes and that can skew your results at the end. The etiology might change over time. So this is weird, isn't it? So the example I thought of here was stomach ulcers. When I was a kid at medical school, stomach ulcers happened because you had too much acid. And then one day someone came and said, that's not true. Now it's because you have Helicobacter infection. And so suddenly the cause of the disease had radically changed almost overnight. Okay. And you can imagine if some poor bugger was halfway through an observational trial on stomach ulcer at that stage and said, crap, PhD in the bin. Okay, because overnight the etiology of that disease changed. It doesn't happen very often. And musculoskeletal is a bad example, isn't it? If you come from a motorbike, you always smack your head in. Okay, so the etiology doesn't radically change. You can imagine rheumatoid arthritis, say, again, when I was a kid, it was all over the place. Older patients, crooked knuckles and so on. Nowadays, you just don't see it because we can switch it off early on. So the etiology of joint disease has changed over the years. Confounding bias, of course, we can't control those for Leo's factors. Case control studies. Now, it took me a while to get my head around these as to try and work out what the difference between this and a cohort was. And essentially what you're doing here is you're taking people with the disease and without the disease and just looking back and going, well, what was different between them? And that's it, kind of a point in time type thing. It's always retrospective. And you're trying to evaluate the impact of an exposure. So you look at people with mesothelioma, which is due to asbestos inhalation, versus those who don't. And you look back and say, well, how many of the asbestos guys had, how many of the mesothelioma guys had asbestos? How many of those without it had it as well? You know, does that add up to be a risk factor? Maybe it's something else and so on. Do you see what I mean? So you look at people with the disease and you look back and you go, what's the risk factor? Rather than in cohort studies, you get people with the disease and you look forward to see what happens over time. All right, so evaluates the effects of an exposure. You can't look at the incidence of a disease then, because what you're doing is you're sat in your office and when they get an ACL down in their Royal London ED, they phone you and say, got an ACL for you, down you go. You're not sat there going, right, there's been 100 patients today and 5 had ACLs. So that means today's incidence of ACL rupture has been 5%. You can't do that with a cross-sectional study. That's what incident and prevalent is talking about. We'll skip over that slightly. You need controls with these, so you need to try and match patients with the disease with similar patients without the disease to try and work out what's different between them. Okay, and that can be quite tricky and quite labor intensive. And you have to be careful how you match them, because if you match them for the factor that might cause the disease, then suddenly you can't detect that difference. Does that make sense? So if I'm asking, well, look, which causes more ACL injury, rugby or football? I'm going to get everybody with an ACL injury, but I'm going to control for what sport they play. I'm only going to pick people who played football. I'm going to match them. They're both football players. I can't then tell if there's a different sport that caused it. Yeah? It's obvious when you think about it, and you never do it, I'm sure, being professionals. You never know. All right? The outcome of case control studies is odds ratio. So top tip number 3, whenever you see odds ratio reported in a paper, it's usually bollocks. Because odds ratios are just intuitively harder to understand. Okay? So you have to read the paper very carefully to work out why are they using odds ratio and how are they using it, and think very carefully about what it's actually showing you. So an odds of 1 to 1 means it's the same. Yeah? So 2 to 1 is just harder to conceptualize than a risk ratio of 1.5 or 2. All right? So odds, so it's the odds of being a case in the exposed group versus the odds of being a case in the unexposed group. Yeah, that's the face everybody pulls. Yeah, it doesn't really make any sense, does it? Right? It's complicated. I'll try and go over it again when we come to stats. But it is complicated. It's worth reading about. There's only really risk, relative risk, absolute risk, or odds ratio that you need to really understand. Okay? And the 95% confidence interval, which is a hypothesis test, which is something different again. Lastly, cross-sectional studies. So this is where you go, right, today, on this day in East London, how many people have COVID and how many don't? Okay, we carry out at one point and we say, today there are 42,000 people across London with COVID. Bang, done. It tells us nothing about how they got it, how they're going to do in future, what effect treatment's going to have, it doesn't really tell us anything at all. You can describe the population who have the disease, but really only in an abstract sense. You can say, well, 50% were school kids, 50% were working, 50% were this age, and so on. It doesn't tell you the incidence, it just tells you how many today have it. It doesn't tell you anything over time and so on, but it is real quick and real cheap. That's kind of the first step you do, like say in an audit or something. You say, well, on a Monday, so many people turn up with this particular injury and so on. There is a variation on that called longitudinal studies, where you might take a snapshot today, you might record all their names, and you might take another snapshot in a month. And you might say, okay, how many of you have gotten better? How many of you today have taste and smell disorder and so on? And that's what things like Children of the 90s do. I only say because I was out of Bristol. I remember it being a big thing when I was an undergrad. Okay, every year they snapshot the state of health of all these kids who are now in their 30s, amazingly. And they've followed them since the day they were born. So every year they do a snapshot on Children of the 90s. And they say, have you had, it's a massive questionnaire, I've seen it. Have you had heart disease, lung disease, cancer? Are you married? Are you this? All these things. It's quite amazing. So you can keep doing that. And this is the sum they do, number of with the disease at a single point over total number studied at the same point. That gives you your prevalence. So these things, they're quick, they're cheap, they're really easy. They're quite suitable for rare diseases. If you can do a snapshot, say the whole of London, every disease in the world represented in London. If you do all of it, you pick up some really crazy, weird diseases. And remember, rare diseases typically go to certain centers. Yeah. So they're easier to find than you might think. You can look at a wide range of risk factors. You don't typically lose them to follow-up because you ask them that day. It doesn't matter if you ever see them again or not. You're doing a standalone cross-section. Having said that, if you sit and ask someone, every COVID patient today, where did you get COVID? And this is what, if any of you have had COVID, then they phone you up, don't they, say, well, where was your exposure? What did you do last week? And so on. There's recall bias. So people don't remember. Because, they ask me, did you go on public transport? I'm like, well, yeah, like twice, 3 times a day, every day. I don't know who I sat next to. I can't remember if I've sat or stood or whether I wore a mask or not. People don't remember. So recall bias is a problem. You can't really show causation unless it's something blindingly obvious. Like everybody you speak to went to a certain, football match or something. Football's really featured today, isn't it? Do you know what I mean? So causation is really hard, and it's not always suitable when the exposure is rare. So asking everybody in London, did you go on public transport? Most people probably say yes. If you say, did you go outside? Did you walk somewhere, or did you go public transport? Everybody would say yes. So the exposure, is really, it doesn't help you at all. And same when the exposure is rare. If you say, did you sit next to a Labrador with a black tail? Unless somebody in that group did, you're never going to know. So that if the exposure is rare, it's not so good. If you can't hunt for it, you just take what you're given. If the exposure is really common, it's meaningless, doesn't help you. So that's it. So we are 1 minute over. Bang. That's why I got a bit quick towards the end, because I'm desperately keen not to be someone who says we won't overrun and then overrun. So we talked a bit about different study designs. We laboured the point on clinical trials a bit, because that's really what we're interested in by the time we get to this stage. The other ones are for easier kind of studies to do and so on, and there might be pilot work or there might be background work and so on. We talked a bit about the advantages and disadvantages of each. The clinical trials weaved through it, the others in more of a table form. And we've talked a little bit about choosing appropriate design for a given question. And that's it. Thanks very much, everybody online. Sorry you didn't get too many questions today, but I'm sure you secretly appreciated that. Any questions at all? Leo's tired, so we're going to draw a line under it. But thanks very much.
Thanks, Brian.
Thank you very much.
No
Cheers.
worries.
Thanks, Brad.
See you later.
Cheers. Bye now.